when you talked about the patient contribution to data, the question really is, how can we ensure from the sort of evidence side of clinical decision making, how can we ensure that patients are contributing to the evidence without vomiting it? In the words of Liz, I mean, how can we actually get this sharing going? Enda, I don't know if you could say any more about that slide where you were talking about the data that was producing in the Oxford project and where patients can contribute their data.
I think, and this is it's more practical example maybe in what we've been doing in fertility or in and around, say, pregnancy, maternity, or more so in the private sector where patients may be moving from clinician to clinician and there's no ability to, at the moment, they've got to go and request their notes and their notes then are transferred. There's no ability to transfer digital imaging from one center to the other unless you're taking it in a memory stick. So what we have with, for example, in fertility, if a patient comes along for IVF, we want them to upload through their patient portal their previous history, their previous records, their previous maybe IVF experience, their blood tests from the GP that maybe we haven't got because they're from somewhere else. So it's more of that what would have been hard notes as opposed to here's my heart rate over the last 12 hours. That's actually of less importance for us at the moment. So again, it's more of the non-sexy stuff data as opposed to the big data, which would come later.
Right. Yes. So we've a way to go in the sort of personalizing in the personal data that's coming into it, so that the patients become individual in the project that their individuality is visible to the clinicians they're dealing with.
Yeah, but you can do if you, I think, my perspective, if you get the infrastructure right on your digital platform, then you can do your plug-in of your apps, so that if I have uploaded and you've uploaded in your patient portal your basic blood test, your AMH reserve, then there are those apps that you can plug in that will say we can now export that into the app that will give you a predictability of what's going to happen. And you can have an input into that data being transferred into that app.
That's great. Thank you. Now we have another question here, which is, with healthcare appointments with GPs, consultants, etc., being increasingly used for individuals with mental health needs, how can digital offer be beneficial to services who support people who have needs with their mental health? So would any of the panelists like to contribute to that one?
We've done a pilot work on this up in the north of England, where we've been working with some mental health trusts on using teams, reconfiguring teams, so that you can actually have group sessions with non-identifiable. You can have breakout rooms. So again, you can set up infrastructure digitally that would mimic what you would do in a real life scenario. Now, then, if you want to in that, and if there is the buy-in from the individuals, then you can plug in things like the Microsoft soft data analysis of interactions and sort of non-verbal cues. So again, it's basic stuff, not the wearable devices, again, sexy stuff, but it's how do you get a group of people together for a group session in a COVID scenario, and how do you keep privacy, and how do you protect data, and how can you pick up on non-verbal cues, that sort of stuff. And those few trials we've done have actually went extremely well, and now they are being picked up by other trusts.
Thank you. And a question for Luke and Bryn, which concerns really third parties. I wouldn't really call them third parties, but the parents of young people who are at Prior's Court. Do they, the data collection project and the big data analysis projects and so on, are the parents contributing both data and hypotheses into this work to try and predict the adverse incidence with young people?
So currently, a lot of the data that's recorded within prize courts is quite sensitive. So the parents have a much more simplified version of the system that we have. So they see less information about the young people than we do. And in terms of their input into the system, as they don't see the full version of the system, at this stage, it's hard for them to make suggestions as they don't see the same system that we see.
But things like when you're looking at diet, I mean, I found that very interesting when you were looking at the influence of diet and so on. That's the sort of thing where I suppose parents could contribute their perspectives and their evidence on that.
Most definitely, yeah. So the parents are able to see everything that their children eat. However, with our data, with the case study that we did there, it was very hard to see it was hard to see the trends coming together until we collated it together into the graph. So the parents wouldn't necessarily make that association there. So until you it's about using the vast quantity of data that we have and then actually using it rather than, at the moment, it is just on the system, and it's about finding ways to collate the information.
Yeah, in regards to actual inputs from the parents themselves, no, it is not currently. We're not getting the information of what they are, say, eating at the household, which is why you saw some quite significant drop-offs in just consumption in general. And it's just because the data wasn't there. I think that is something that's being looked into, but at present it's not available, which is unfortunate, especially when some individuals do spend quite a significant portion, say they go home for weeks at a time, go home every weekend. And if certain family members aren't religiously following specific guidelines or being as consistent as staff are here, there is going to be some discrepancies in data, but it is, I think, something that is being worked on.
Thank you. Yeah. And then, Stuart, the importance of the collaboration between the Topol fellows. I'm struck by something that relates back to when the digital healthcare science course was in evolution. It was a previous chair of our department, the late Lord Bhattacharya, who was talking to a previous Secretary of State for Health, and their joint conclusion was that in health there were two tribes, essentially, that the investment of health into digital had gone to getting more digitally literate people into specialized services, health informatics, etc., and telehealth. But the divide between them and the frontline health care team was a very, very deep chasm. And it strikes me that from what you were saying, that whether as a result of Topol or whether as a result of the pandemic or a variety of complex influences, that the need to develop health and social care and the need to develop it digitally has coalesced enormously.
Yeah, Ed, I do. I think that the stories that I've told today and that we could tell about other Topol fellows are very much about kind of expanded tribes. In that, I think there are still tribes, but that the kind of these are stories of clinicians working with more, let's call them, for the sake of argument today, more purely digital roles in kind of equitable collaboration to make things happen. And I think the power relationships or the relationships are fundamental. And I think that well, certainly the pandemic, how did it happen that we got to more digital services? And I think probably what you've hit on there is exactly what happened, is that, well, we didn't just buy software and switch it on, because that would have done nothing. We got the clinician and the people that would have procured the software, and the informaticians or the IT team or the people looking after the firewall so that actually the messages could go out. And then these people had to work together rapidly and quickly, and perhaps more than they previously had done. So if you like, those tribes came together. So let's call them one tribe now, but I know I'm oversimplifying that hugely. And I think that the possibly one of the that last point I made about career pathways is about, well, where does that tribe go? So those relationships have probably been enhanced better and quicker than ever. But they've probably shone a light on the need for the greater investment in the size of those teams, but also a route to some people are so wedded. Some of the, particularly the digital clinicians that we've worked with, are so wedded to the kind of work they've done that they want to stick with it. They don't want it to just be this opportunity that they were so fortunate to have. And it's hard for them to see how to take that forward within the particular healthcare profession. We've got chief nurse information officers, but we don't have the same for AHPs, just to take one example. So there's clearly much more work to do there, but I do think you're quite right that the pandemic has forced relationships that were in place, but maybe not as not in such great volume, and there was quite inequity between the more advanced and the less advanced trusts, where in terms of digital, and we just had to get on and do in a way that's advanced those relationships. So I think that's a really good observation.
And there's a follow-up question for you on the site, which is about how can we get this sustainable? Would a requirement for the employing trust to give them some trust time after the end of the fellowship be helpful for that?
I'm absolutely, of course. You're not going to say no to the time ever. So yes, of course. But so to make it a condition, yes. We've thought long and hard about this. How do you, because this is funding going from HEA to trusts, and the more that we can see trust buy-in, the more we'd like to back the trust. So we've been asked questions about, well, should it be a 50-50 investment? And that might be fine, but it might actually then favour the already wealthy. Let's just put it that way. But that we are trying to think about those models that sort of structure even who we recruit to be fellows, so that we don't just get these enthusiasts that are phenomenally brilliant individuals. We need them to be surrounded by a great trust or a greater team or more support. And if that's one way of doing it, so be it. Yeah, that's a good idea.
And one last question for Enda. How do we train healthcare professionals to become expert digital professionals in the Oxford Digital Hospital?
So the first thing I would very clearly say that I'm not a digital expert, but and that's again very clear. I went to medical school and I didn't go to an IT school, and I think that is where doctors can sometimes have a bit of mission creep. We're usually reasonably bright and able, but we need to know that where our limitations lie. And I think where we can serve as a real role is that we can help to scope what is needed. We are in the front line. We know what our frustrations are. We know what we want. We know the experience we get when we go to Amazon or we go to our bank or we go to that. And then we need to be able to vocalize those and socialize those problems with whoever is the correct digital people in our establishment to actually create that. And don't try to reinvent the wheel. There's Microsoft, an example, have got so many tools out there, and they're spending billions every year on different platforms. All we need to do is take that Lego brick and reassemble it in some way, and then make it effective to what we want. And their security systems that they're spending around cloud-based security are far superior to what any trust is going to spend as an individual or any organization. So don't try to reinvent the wheel. Don't try to be somebody you're not somebody, and talk to people who understand what the frustrations are. So do your scoping with your nurses and with your porters and with your doctors, understand the problem, and don't just give them a, here's Cerner, here's Epic, take it. You've got to go, really? Really?
And I said that was the last question, but I've got a last question for you, which is, does the digital landscape accommodate effectively a multidisciplinary approach to the care and treatment of an individual patient with several health conditions? So we haven't really talked about multimorbidity yet, but it's a really key question. Could you just give us a quick reflection on that?
Stuart's got his hand up there, so maybe let Stuart do it.
No, just to hands up, just to say I've got something to share on that. But Enda, please go first.
Well, so again, I think the answer is in those people are living longer, lots of comorbidities, lots of touch points into their care, and it is again going and scoping what we want correctly, and not actually handing us as healthcare professionals what you think we need. It is actually understanding the problem and devising the solution to it, and not believing that one individual's got the answer to this.
Stuart, thank you.
Yeah, that's a fantastic question, and it's one that we've encountered. So as a way of answering it, I probably want to say a few things about some of the fellows we've got on cohort 2. So, I mean, one of the privileges of being part of this program is that we get lots of extremely clever people coming to us saying, this is broken in the NHS, I want to help fix it. And their application effectively is a story of something that's broken that they want to fix. So if we get lots of applications, we see that we've got this unique insight into stories of things that need fixing. And in fact, we've commissioned some work to do some analysis of, what are the common trends. But I put in quite a bit of time to shortlist at least 100 of the applications that we got for the current fellowship. And time and again, and we've got many fellows trying to solve this sort of problem, time and again, the problem was condition specific, which brings me closer to the question. So we've got fellows working in, I'll give you a few examples. One of them is one of them is a kidney transplant surgeon. One of them is a nurse out in the community, working to ensure that the multidisciplinary care plan for patients being cared for in the community happens. One is an A&E, pediatric A&E doctor working in a children's hospital, working on vaccination status of children that come into A&E. And another is one working on a midwife working on multiple births. But if you abstract what they've come to us out a little bit to try and solve, the problem they've all come to us to say they want to solve is that in my specialty, at the condition level, the data's in multiple places. Plenty of people have said it today, and we spend a lot of our time finding it, pulling it, searching for it, not finding it, having to ask for it again. And I've agonized quite a bit over, are we doing the right thing in supporting or in looking for change just at the specialty level or at the condition level? Because the very intelligent question that the questioner has asked here is, well, does that, if I've tied together everything that I need in order for the patient to have their kidney transplant, but I might not know something else about another condition that's fundamental. Yeah, I've done brilliant at coordination along the pathway, but I haven't connected the pathway to the other pathways they're on. And of course, the central patient health record is the kind of holy grail there. And one of our fellows, who's a community nurse in Gloucestershire, is working on this and really knocking heads together so that all of the different teams that feed into the care of patients in the community, whether they are private providers, whether they're in social care, whether they are paramedics visiting these patients out in the community, have access to that shared care record. And that's a project that's trying to kind of organize the data around the patient and not organize the data around the condition. But I don't have a perfect or even a good answer to the question. But what they are hitting at there, which I think is very, very sharp, is the question that we must pay attention to is, are we solving digital problems at a condition pathway level only? And is that enough? Because of course, surely it's not. And yes, it's a risk, isn't it?
Well, you've brought us very, very nicely back to the absolute nub of today about clinical decision making, that it's not just organizing data around condition, data being a shorthand for evidence. It's organizing data and values around patients. And we are a huge way forward, but it is clearly a long way to go. And so on that, I'm going to hand over to Ashok as